Good evening, and thank you for joining us for Conversations Live Joint Replacement. I'm Patty Satalia. It's estimated that 750,000 Americans undergo joint replacement surgery each year. The procedure offers the potential for pain relief and increased mobility, but it may not be a permanent fix, and joint comes with permanent risks. Is it right for you? Tonight you can discuss the pros and cons of joint replacement with our panel of experts. Dr. Wayne Sebastianelli is an orthopedic surgeon with Penn State Orthopedics and the director of Penn State Center for Sports Medicine. And Dean Plafkin is the lead physical therapist with Penn State Orthopedics. Thank you both so much for joining us.
Thank you for having us.
That number is staggering, 750,000 joint replacements each year. Why are we burning out our joints?
Well, it's multifactorial. I think it's based on activity levels. I think it's based on the inherent weight issue or weight problem that's ubiquitous throughout this country in particular, but also worldwide. And people are more active and are taking more risk later in life.
One of the most startling things I read is that the fastest growing group getting hip replacements and joint replacements is those age 46 to 64.
Scary. And the reason why it's scary is that, you know, it's not a biological solution. So what's put in a 40-year-old will clearly need to be revised at least once during their lifetime, and probably more like twice if they live into their late 70s and 80s.
So what factors, Dr. Sebastianelli, determine how long an implant will last? Because I've read 10 to 15 years. There are people who got hip replacements 20 years ago and they're still going strong.
Sure. It's based on activity level, how much risk an individual takes. It's based on kinetic energy, 1/2 mv squared. So if you're a heavier patient, you do more ballistic activities, there's more kinetic energy applied to that joint. And then there's other issues like surgical technique. Was the implant put in an appropriate alignment? Was it off balance? Just a little, little bit, just a few degrees off kilter, so to speak, and it leads to a very, very extreme escalation of the wear patterns of that joint.
Now, we talk mostly about hip replacements and knee replacements, but really any joint can be replaced. Is that right?
That's correct. The ankle joints, knee joints, elbow joints, shoulder joints, hip joints, even the little fingers in your hand have joint replacements, wrists, even foot, the toe, the big toe. But high stress areas tend to have high failure rates, and some of these areas really don't have good survivorship to warrant joint replacement.
Now, rehabbing after a joint replacement requires tremendous physical and mental effort. But I'm reading a lot about the need for prehab, as that being as or equally as important to rehab. Tell us a little bit about the condition that someone ought to be in before they undergo hip or knee replacement.
Well, you're correct, and there is research that suggests that those patients that undergo a prehabilitation program actually do better once the surgery is performed. And obviously, the better condition you're in going into a surgical procedure like that, like a joint replacement, the better you will do coming out of that surgery. Typically, if all things are equal, someone who is going in fit and maybe has their weight under control a little bit better than someone else, we would expect that they would respond and do better following the surgery.
And of course, anyone who's having a hip or a knee replaced is doing that probably because of a mobility issue or a pain issue, which would limit what they can do. What would be your prescription? And of course, patients are individuals, but generally speaking, what would a good prehab program entail? Well,
we would probably work at a base of to get an aerobic base for the patient, whether it be activities such as non-weight-bearing, non-load-bearing exercises for the joints, biking and or water exercise would be something they could be doing. We'd also advise the patient in an exercise program that can develop strength and muscles that will be key to their outcome from a functional standpoint. For instance, if someone's going to undergo a knee replacement, or if they have osteoarthritis of the knee, we may be doing exercises that really work to strengthen the hip and the quadriceps, two muscles that the research suggests are very much a key for someone to return to functional activity and do well with such things as transferring in and out of a chair, walking steps, or even moving out to higher level activity.
We'll talk about rehab in just a moment, but the president of the American Academy of Orthopedic Surgeons says that, quote, people may be overly optimistic about what joint replacement can do for them. What are realistic expectations?
The basic premise for joint replacement is to provide comfort. Function is secondary. So if someone has pain that is literally interfering with activities of daily living, interferes with sleep, interferes with a relatively normal lifestyle, and the individual cannot tolerate the discomfort even with the use of multiple medications, then it's time to consider a joint replacement. If a joint replacement is being done for an occasional ache or pain or some stiffness or just an inconvenience, it's really not the right time to do a joint replacement.
Okay, you can join the conversation. Our toll-free number is 1-800-543-8242. You may also email your question or comment to connect@psu.edu or tweet your questions to @WPSU More and more, 20 years ago you never heard of this, but today people will undergo double knee replacements. Mm-hmm. Why is that possible today, and it was something unheard of just a decade or so ago?
Well, I think it's possible today because of the ability for anesthesia and for fluid management, blood transfusion techniques, so forth, to really control the patient's change in metabolic status and fluid status for those cases. It's not something that we really push for because it's fraught with increased complications. It is much more demanding on the cardiac status of the patient, the pulmonary status of the patient. The complications that we worry about with joint replacement include pulmonary embolism or deep vein thrombosis and infection.
Blood clots.
Blood clots. So with 2 incisions, being on the table twice as long, being relatively immobile twice as long, even though you're up and moving, you're still not moving as well as you would be if you just had one joint involved. All of these risk factors go up. So if you're a relatively healthy patient, it's a consideration. If it's someone who has comorbidities like diabetes, obesity, immune system dysfunction, cardiac issues, pulmonary issues, you probably shouldn't do it.
The advantage, of course, is a shorter rehab.
Correct.
One rehab and two joints corrected.
Correct.
Okay. We'll go to our first question. It comes from Marion, who's calling us from Myersdale. Go ahead, please, Marion. What's your question?
Well, I'm 63 years old, and last February of this year, I had a hip replacement. So, of course, mine was an emergency surgery because I was standing on an unsafe surface, and I fell to my side, so I fell downhill and on my side. So my surgeon told me I didn't break my hip, I shattered my hip. So I had one surgery, him trying to piece me together, that didn't work. So then I had the titanium surgery, and that did work. But here's my question. I walk with a limp now. The leg that I had replaced, the hip I had replaced. Now, I don't know, does everybody that has hip replacement surgery walk with I mean, my one leg is, longer than the other now.
Now, she's a revisionist, so she's had 2. Revisionist Sure. might not be the right word, but she's had 2 replacements, and that, of course, complicates things.
No, that's correct. And it sounded like she had a hip fracture, and the fracture was treated with a biologic solution, which was internal fixation, and it did not heal and led to recurrent pain because of the joint being irregular or the fracture fragments being loose, and that led to joint replacement reconstructive surgery. What happens in those instances is that it's very difficult to get the muscle or the soft tissue envelope, as we like to call it, to be back to normal. So there's either going to be some scarring or the attachment sites of the muscle to the main fragments of the femur and the pelvis are altered because of the fracture. So again, it's all biomechanics. If it's not hooked up the right way, if it's not at the right angle, it can't pull the bone in the same direction or with the same amount of force, so that leads to the limp.
And how common is a limp after hip replacement surgery?
If it's an uncomplicated hip replacement surgery and there was no significant muscle problem prior, and the leg lengths are within half an inch of being equal, there's very, very little limp.
And does Marion have a recourse? I mean, is there something she can do to at least reduce the limp?
One could consider adjustment of her shoes or footwear so that the short side is lengthened with an insert. One can consider looking at the attachment of the muscle sites, and if there's a potential to transfer the abductor muscles by transferring the attachment site, you could consider that it would improve the muscle function.
All right, thank you so much for your phone call, Marion. We go to Pat, who's calling us from Johnstown. Pat, you're on the air.
Talk about the rotator cuff tear, and it's not able to be repaired. That the big major surgery is going to go. What is there anything you can do besides the surgery, or is that the only thing that can be done?
For a rotator
cuff?
Yes.
Well, I mean, that really is a problem that in many instances is unsolved, but there are types of joint replacement for the shoulder that deal with soft tissue deficiencies such as an unrepairable rotator cuff. And we usually call those oversized hemiarthroplasties, which is basically putting a large ball into a big hole, or a reverse shoulder replacement, which puts the ball in a different position compared to what the traditional shoulder replacement is. Both of those are salvage operations and really should be done only for pain management and really not be expected to improve muscle function or range of motion.
Now, 9 out of 10 hip and knee replacements are successful. How about for rotator cuff replacements or shoulder replacements?
Shoulder replacement for arthritis, very successful. Again, into the 90, mid-90 percentiles.
Okay, we'll go to another question in a moment, but I'm wondering, from a physical therapy point of view, what might you recommend to our caller who's calling about a rotator cuff problem?
I think a lot of it would depend on how much pain she's having. And what we would do in physical therapy, if the pain certainly were manageable, first of all, we would try to manage the pain, but then once that happened and we were able to establish that we could control pain, we'd start to work on some gentle strengthening exercises in an attempt to enhance her movement within a range of motion that she was capable of getting. For instance, a patient comes in and is having difficulty, let's say, doing something with their hair, doing hair care. A goal might be that we work on trying to establish a little bit more range of motion, a little bit more strength to allow them to do that. Trying to be realistic with our approach, not trying to do too much, because sometimes with this patient, trying to be too aggressive with strength, and you can actually end up increasing their pain and results in going backward where they can actually do less.
Okay, we go to Dick, who's calling us from Johnstown. Dick, go ahead, please.
Thank you. I'm going to quick comment to Dr. Wayne Sebastianelli, who I've watched prowl the sidelines at Penn State for many, many, many years. My question, Dr. Sebastianelli, is I live in a town that has a teaching hospital here in Johnstown. And I've noticed they have billboards up. And the billboards proclaim that they're in the top 5% for joint replacements. Why go anywhere else? And it occurred to me, what criteria do they use to say they're in the top 5%? And without knowing that, is the billboard perhaps a bit disingenuous? Thanks for taking care of Joe.
You're welcome. You're welcome, Dick. That's an excellent question. It's not a simple answer. What people are comparing are infection rates, blood clot rates, pulmonary embolus rates, dislocation rates, nerve injury, loosening, readmission rate to the hospital, all those things. And it's hard to compare because some cases are going to be a lot more difficult than others. And a hospital, say like, Hershey or Danville are going to be doing more difficult cases necessarily than maybe what's being done in a small hospital in St. Mary's, Pennsylvania. So it's I'm not going to pick on Johnstown. So it's one of those things where it's hard to know for sure, Dick. But I really think that they're just looking at basic issues such as readmission to the hospital shortly after surgery, instability, blood clotting, and infection.
What kinds of questions should someone ask a potential physician, the one they want to hire to do their joint replacement?
I think whether they're board certified, everybody should have board certification. Whether or not they've had experience doing this recently. So if you're an occasional joint replacement surgeon, it's a lot more challenging for you. If you're doing, 25 to 30 or more a year, you're pretty experienced. And what kind of implant are they using? Is it something that's tried and true, or is it something that's the latest and greatest and has this big reputation but has no science to back the reputation? So those kind of things are very, very important to stress. And then finally, the one thing you should ask your surgeon, is there any financial interest in you putting that implant in? Because a lot of times people are hired consultants for a certain company, or people have really led to a design of an implant and they may be biased as to using that implant. So you need to be careful about that sometimes. I have issues with that personally. A lot of professionals have issues with that, but it's something that you need to be careful about. Someone's fully forthright and they've designed the implant, they obviously believe in it, and if they tell you that, then that's great, but they should tell you that up front.
Okay, and I want to talk about the variety of designs that are available today in just a moment, but we'll first take this phone call from Rose, who's calling us from Youngsville. Go ahead, please, Rose.
Hi. I have had both knees and both hips replaced, and my last hip replacement was done in November, and they put a pin in at my knee and at my hip, I guess, to put a rod so that they could line up the bone or something in the rods.
Mm-hmm.
From the point where they put the pin in, my leg from my knee down, half of that leg is completely numb, and the whole top of my foot is numb, and I can't pull my foot up. They said I have drop foot.
Mm-hmm.
Do most people come back from that? I mean, is that something that's normal?
Well, it sounds like the pin has interfered with the function of your perineal nerve, and it depends on exactly where about the knee was put in, but it sounds like it got both the deep and superficial branches of the perineal nerve involved or impaired. And as far as recovery, it really depends on whether the nerve was just pressurized or whether it was actually injured with the pin. It's not uncommon to, even without the pins, to get what's called a sciatic nerve palsy or perineal nerve palsy just from stretching the nerve as you're putting the hip joint in. You can have a retractor put too much tension on a nerve, or if you lengthen the leg too much, you can actually put too much tension on a nerve. So it's kind of hard to blame it on the pin itself, but it should be considered to be a pin insertion problem and should be explored that way. But you can get some nerve conduction studies that literally electrically maps out where the nerve is not functioning, and that can give you a better idea whether it's coming from the hip joint or whether it's coming from the pin insertion site.
I couldn't help but think you sound so young, Rose.
That's exactly what I was thinking.
And I'm thinking to myself, 2 hips and 2 knees. Do you mind if I ask, is it arthritis?
Yes. The cartilage was completely gone in all of them. And I'm 57. And 3 weeks after I had the hip replacement, I was sitting in my chair watching TV, talking on the telephone, and my hip completely went out of joint. I had to have it put back in, and then I had to go to a rehab hospital for 2 weeks after that. And so now I'm very leery on everything I do because I was just sitting.
Mm-hmm.
What's your input on this, Steve?
Well, my question to Rose would be, how long have you had the drop foot?
Ever since the surgery.
Yeah, how many months is that now?
I had it done in November.
November, okay. Well, I can just tell you that I have seen patients in our clinic who have suffered from a drop foot at times, and the one piece of advice I would give you is to be very patient, because there are several people that have come through our clinic at one time or another who from the 12 to 18 month mark started to really make some gains on that. And in fact, one person I have dealt with personally, her goal was to play tennis. And anyway, to make a long story short, her function in her perineal nerve, or her ability to move her foot up against gravity, fully returned.
And are there recommendations in terms of what she can be doing? She's not your patient, so this can be a little bit dicey to recommend, but are there particular exercises that may help her?
I think the big thing is time and allowing the tissue, the nerve to regenerate. There is some research that would suggest there are possible modalities that could influence that, but I don't think there's anything concrete.
Okay. There's actually two things. Number one is give consideration to having that nerve study done, because if it looks like it's a very, very local problem, then sometimes it's just scar tissue around the nerve, and that can be fixed, just like carpal tunnel can be fixed. The second is that in order to prevent your ankle and your foot from being in a bad position because of the muscle imbalance, you know, her ankle wants to be continuously what we call plantar flexed, or move towards the floor. There are dynamic splints that could be worn that will help you walk better, and it will help keep your foot in a better position so that you won't trip over your foot as you're walking.
All right, thank you so much for that call. We go now to an email, this one about infection, something, one of the major risks involved in joint replacement. This questioner asks, what is the incidence of infection during joint replacement? What type of infection? What is the severity of these infections?
All infections when it comes to joint replacement surgery are very, very potentially serious and are taken very seriously by the treating physicians. Any type of bacteria could be involved. You hear about the real sort of nasty bugs like the MRSA, or methicillin-resistant Staph aureus, MRSA, or vancomycin-resistant Enterococcus, VRE. But even just simple staph or simple strep, or E. coli from a urinary tract infection that gets spread into the hip or knee joint, they're serious infections, even though they're simple.
And it's not just right after surgery. Infection is a concern through the
lifelong. And an immediate infection after surgery is usually something related to the skin, so mostly staph mechanisms. And requires aggressive treatment with antibiotics. Sometimes salvage of the joint can be obtained, but in most instances you're talking about re-exploring the wound, washing it out, replacing the plastic parts so that the metal parts stay in, because they're harder to remove, and trying to buy salvage to that joint. If that fails, then you're looking at removing every piece of the implant, putting in a temporary either cement spacer or some type of articulated spacer, and
until someone can undergo surgery again, which could be 3 months.
Usually it's at least 12 weeks. That's correct.
All right, so infection is something you want to avoid at all costs, and in fact, surgeons who do the kind of work you do, if someone presents for their operation and they have even the slightest fever, you're not going to operate, or a respectable surgeon wouldn't operate.
That's true, and sometimes it's an inconvenient, stressful decision. I recently had one where I had someone scheduled for joint replacement, and came into the same-day surgery admission bay and had a temperature of 100.2 or 100.3, which you never know where they're at, what that is, whether it's bacterial, whether it's viral, and to take a chance of having bacteria in the bloodstream while you're going to put an artificial part in is
risky business.
Very, very risky.
All right, we go to Lena, who's been patiently waiting in Center County. Go ahead, please, Lena.
Yes, I want to ask the doctor a question. I had a knee replacement did about 6 years ago, and when it first happened, I was working in my knee. I was dragging my knee trying to work, and I couldn't hardly walk. And he told me that bone was hitting bone. And then maybe about 2 years ago, or 3, it developed bursitis in it. So why did that happen to my knee? And it still hurts from that, but it don't hurt from the surgery. It just hurt from that. So he said it was bursitis. So I don't understand that. Could you explain that to me?
Sure. Sometimes what happens is that some of the pain that you're experiencing, Len, is coming from tendons and or the sac around the tendon that allows it to glide back and forth over bony prominences, that's called a bursa. And if those areas are prominent and inflamed or scarred, they can continue to hurt. Sometimes tendons just degenerate, and my colleague here deals with that all the time, trying to get that tendon pain to go away. Well, you can get rid of the joint pain with a joint replacement, but you're not going to get rid of tendon pain with a joint replacement.
So let's talk to Dean. What can she do?
Well, I think it would probably be wise to look at the complete link from she had a knee procedure, but to look at the hip and the foot. Perhaps there's some interventions that could occur that could help what's happening at the knee. For instance, strengthening her hip may allow the femur, the bone, the top bone of the knee, to be in a little bit better position, which may take stress off the tendon. Or if she had a flat foot, maybe some type of insert for her shoe, or if she had a very rigid, high-arched foot, mobilizing and stretching the foot might allow for a slightly different position of the knee with walking that could start to unload the sore, painful tissues.
How about ice? How important is ice for someone with bursitis?
Ice can be very helpful in managing the pain. Primarily, that's what I recommend ice be used for. I think there's claims about swelling and other things, but primarily I think it's been shown it can reduce pain. Not for all patients. Sometimes in more chronic situations I find that pain may actually be increased with ice. I have patients tell me that. I can't stand the ice on my skin. So at that point, perhaps superficial heat might be something that would be, an analgesic effect for them.
All right, we go to Kathy, who's calling us from Brockway. Go ahead, please, Kathy.
Hi, I was hurt in 1996, and the muscle from my lower back to my hip was pulled real bad, and I have trouble with my hip, stand in place. Like it'll just kind of try to turn, and when I walk or twist, and I have a chronic. They did an MRI on me, and I had a chronic tear show up on the on the MRI, and I also had an overhanging neck spur and an impingement. And I'm in a lot of pain in that leg, and I already did have the back problem to begin with, and then it's on the side that my back problem is on. So I don't want to end up not walking, and my back has gone out so many times, over a period of 20 years. I could say it's probably gone out 14 or 15 times. And I always went to a chiropractor, and I never had any trouble. They put it in place, and I'd be fine within a week. And this last time, it went out really bad, and I was getting up out of a chair, and it just swung real bad, my whole pelvis, and pulled the muscle in my lower back and pulled it down to my hip. And I don't know. It's probably from the accident I had in '96 that did this. But anyway, I don't know what to do for it. I get frustrated because I don't think hip replacement is the answer, but I wish somebody could do something to take some of the pain away.
Dr. Sebastianelli?
Yeah, this sounds more than just a standard hip joint problem. This actually sounds more like a sacroiliac, lumbosacral problem, even disc degenerative problem, and really should be evaluated from the foot all the way to the top of her head, because if there's even a scoliosis associated with it, it's going to put more pressure on these areas that's going to lead to the susceptibility of that sacroiliac joint dysfunction. So it's kind of hard to know exactly where to start, but
an MRI, is that
good physical exam, standing assessment of her pelvis, whether her pelvis is horizontal to the floor, parallel to the floor, whether or not the leg lengths are unequal, whether or not there's a rotation of her pelvis. And Dean would be the perfect person in the sense of the type of specialty that would be able to assess that and treat that. But there's little joints and big joints in the pelvis, and the sacroiliac joint's a fairly large joint. It's usually fairly stiff. So, but if you injure it and those ligaments are incompetent, then at this point in time it could sort of slip out of place and lead one side of your pelvis to rotate compared to the other side, which will really be very painful.
Many times with a physical exam, we can determine movement patterns that would suggest or lead us to think it's the hip versus the back. And I feel that in this particular case, it would be wise to really have, as Dr. Sebastianelli said, the back worked up to evaluate the back. Not to say that the hip's not a component of this, but from what I hear from her history, I would be suspicious of the back or the sacroiliac joint.
So the recommendation would be to see an orthopedist? I'm not a family doctor. For something like this, you need a specialist.
Someone who's been trained in musculoskeletal medicine, whether it's a sports medicine primary care physician, an orthopedic surgeon, or even a really, really good physical therapist that the primary care doctor refers the patient to. Someone who trained in musculoskeletal medicine assessment.
Okay, we'll take another call in just a moment, but I wanted to ask about options that we're hearing about today that we didn't hear about maybe a decade ago, and that are things like partial knee replacements and hip resurfacing. Mm-hmm. Why would you do a partial knee replacement, and what can you tell us about hip resurfacing? Why would you do it rather than a total hip replacement?
Sure. It's all about preserving biologic tissue. And the more biologic tissue you have, the better off that joint's going to be for an extended period of time. And there's even things that you could do shy of partial joint replacement or resurfacing. They're called osteotomies or realignment of the limb. And that's a pure biologic solution that could buy anywhere from 5 to 15 years of your own tissue. That's great. But the partial joint replacements are done for very focal, very localized problems in a joint, usually related to something traumatic that was direct to the joint, or a blood vessel problem to a certain part of the joint that's led to what's called avascular necrosis, where you literally have like a dried piece of fruit and the piece falls out and that part of the joint's arthritic. You can just replace those segments. In the knee joint, it's usually the medial compartment. In the hip joint, the resurfacing is literally trying to preserve most of the ball and most of the socket and be very, very minimally invasive to those areas, remove just enough tissue to put a metal cap and a metal cup and then a spacer in between, or a metal-on-metal implant, which in some instances we're seeing some issues with that, but those kind of surfaces are out there.
Minimally invasive, and yet I'm reading that hip resurfacing is actually a more complicated surgery.
Very much so. Much more fraught with being put in wrong, in malalignment, much more fraught with fractures, much more fraught with loosening, and even the instability issue, which is supposed to be better with that type of implant, is very, very significant. So
now you mentioned just a moment ago metal on metal, and there was a move to make replacement joints last longer, and so the move was to metal on metal, and lots of surgeons are finding that there are problems with metal on metal.
Sure. Some of them are purely mechanical. The material just isn't quite machined appropriately, or the radius of curvature is off just enough that there's more wear as it goes through a range of motion. Some are having issues with potential ion release, so the metals are releasing fragments in a very, very small nanoparticle type thing, but it's picked up on blood tests. We really don't know what that means yet. So it's one of these things where if it's done for a young patient, and that theoretically it's going to last 50 years, are there going to be issues with heart disease, kidney disease, liver disease? With
these metal fragments actually in their blood system now.
Exactly. We don't know what it really means.
Okay. All right. We'll talk a little bit more about that, but let's take a phone call. We've got Ed, who's patiently waiting in Bellefonte. Go ahead, please, Ed.
I'll try to keep it short, but when I was 13, I went over a high wall on coal strippings. One leg was amputated 3 times, up kind of high above the knee, and the other one was partly paralyzed. Now, because of that, well, it was mostly paralyzed. Because of that, I was immobile for a long time, and when I went back to school, my the femoral head deteriorated, caused me a lot of pain, and they took me out and put me in traction for a long time. I was able to go to school the next year, and the head remained deformed, or it wasn't spherical. I went over another high wall like 9 years after the first one, and when I broke the trochanter, and when they pinned it together, the surgeon turned it so that there was a little bit more round surface so that we could postpone getting a hip replacement. We rushed ahead a little bit, and like 1970, I was in Pittsburgh and having a lot of pain, and one of the top surgeons there said, "This hip is bad enough that I will replace this free if you'll get it done, but I don't know what your finances are about the hospital." And I didn't have any insurance at the time, so I postponed it as long as I could. I was able to postpone it until like 95. And this is where we're getting to my question. I had it done and talked with several different surgeons. One was going to put an incision in the front of my thigh, and the other one, because of one guy going on vacation and my already donating blood and needing to finish the process, I ended up having it done in Pittsburgh. And none of the surgeons ever looked at my leg, and I was concerned with the deteriorated gluteal muscles already. And when the surgery was completed, I never regained the strength in what I would call the back below the buttock. There's almost a crevice there where there should be muscles. And my question is it possible that muscles were detached and not attached correctly or in an appropriate place? Because I get it really a knot. I'm unable to stand up straight, have been since the last surgery. And I'm wondering if there's a way for me to see how the surgery is done. I've never had, when I've complained about it, no one has ever actually taken a look at the musculature and said, yeah, well, this should be attached here.
Dr. Sebastianelli, hard to diagnose that.
Yeah, that's a tough one. It sounds like you had, what we talked about earlier, avascular necrosis, and then a biological solution, which is a derotational osteotomy to try to get the better part of the head into the cup position better so that you would be able to walk on normal joint rather than abnormal joint. And then you ultimately had a joint replacement. It's with all those injuries and all that surgery, there's no question that the soft tissue envelope is going to be damaged and abnormal. And it's kind of hard to know exactly what kind of state it was in prior to the last surgery. So it's kind of unrealistic for me to give you a solid answer. But it sounds like that the muscle itself is scarred and denervated and dysfunctional, and that kind of problem is going to be hard to overcome.
If it were detached, can it be reattached?
Only if it's done within a certain time frame. So if a muscle is detached, and the common one we talked about earlier was a rotator cuff, if it's detached completely and the muscle's pulling on the tendon, and the tendon is just in free space, that muscle will shorten over time and will become fibrotic. And so after roughly 4 months, 5 months of a muscle pulling on a tendon that has no anchor, that'll shrink, and it's going to be very challenging to get that to be functional again and actually reach to where it came from. So it's unlikely after half a year.
Okay, thank you for your call. I'm sorry for all you've been through. We go to Kathy, who is calling us from Brockway. Go ahead, please, Kathy.
Hello. I'd like to ask a question about knee joint replacement, which I view as an amputation taken out of the middle. Is there such a thing as waiting too long, prolonging it too long, having the surgery performed?
Dean is shaking his head, yes.
Well, I think that I have seen this happen in our clinic where a patient has waited and put it off to the point where they develop a second condition, or as Dr. Sebastianelli mentioned earlier, another comorbidity that then inhibits them from having the procedure. And oftentimes they'll be regretful about that. I'm sure Dr. Sebastianelli has some things to say as well.
Yeah, there are things that could happen with joint degeneration, and you could develop what are called erosive cysts. And if that happens, you actually lose bone stock. And usually you see that with inflammatory arthritis problems like rheumatoid disease or psoriatic arthritis, really aggressive conditions. But even in run-of-the-mill standard osteoarthritis, if you have a degenerative cyst and the process is very inflamed and the knee joint becomes bowed, and you have this cyst there, you can actually fracture through that area or create excessive bone loss there, and it's very challenging to fix that at that point. If the x-rays don't change, you don't have those issues, you don't need to jump the gun to do a joint replacement just based on an x-ray. I always tell my patients, I don't treat the x-ray, I treat what you're telling me. And the second thing I tell them is that you tell me when you're ready. If you meet the criteria based on exam, you meet the criteria based on x-ray, and you tell me you're ready, then we go ahead and do your replacement.
What would make someone a poor candidate for a replacement? When would you say, no, I can't do this?
Significant comorbidities, heart disease, lung disease, significant venous dysfunction in the lower extremity, which would lead to high-risk wounds, burn victims with poor soft tissue envelopes, joints that are literally fused. So the soft tissue muscles about the front and back of the joint will not really function, even though you put a hinge in there now. They just won't be pliable enough to create function.
All right. If you are just joining us, I'm Patty Satalia, and this is Conversations Live Joint Replacement on WPSU TV. Let me reintroduce our guest, Dr. Wayne Sebastianelli. He's an orthopedic surgeon with Penn State Orthopedics. He's also director of Penn State Center for Sports Medicine. Dean Plafkin is Penn State Orthopedics lead physical therapist, and our telephone number is 1-800-543-8242. And we are ready to take our call from Dorothy, who is in Frankville. Go ahead, please, Dorothy.
Thank you. I wonder how long it's going to be before you can, there'll be cloning of the tissue, so we don't have to have the knee replacement, so that the
good question.
What's it called that's there now can be just cloned.
No, that's a great question, Dorothy. It's something that we all dream of, just going to a shelf and picking up a bottle and sprinkling an ACL in an athlete or a joint replacement.
If only we could.
Someone. But we do a little bit of that stuff now with culturing cartilage cells and transplanting them into joints. But that's usually again for very, very focal problems. And degenerative arthritis is a global problem in the joint, which won't respond to what we have right now. But people are working hard on that every day. Stem cell research is something that is a hot topic, politically contested in some areas, but it's one of the things that really can be helpful for the future, and the future is bright for a lot of things.
There is one manufacturer, Smith & Nephew. They won clearance from the FDA to introduce for sale a 30-year knee, and there's talk of 15, 20, 30-year knees. Do you anticipate a day where there is a permanent replacement? A material that could last, 50 years?
I think it's possible. I think that, name brands aside, it's very, very challenging for something to say it's going to last 30 years when it's only been used for 2 years. There's always been that in orthopedics. This is the greatest thing coming down, and it's going to revolutionize.
And metal on metal was supposed to be that.
Exactly, and it's not that it's wrong to consider these things. I just think they need to be taken with the appropriate level of caution. They need to be studied thoroughly. They need to be put in with the right indications. They need to be put in by the right surgeons, so that they're put in well, so that if they do fail, we know that it's actually an implant problem and not an insertion problem, or not a patient selection problem.
And how important, Dean, is compliance when it comes to the rehab after transplant or implant surgery? Well,
I think it's very important. I think Dr. Sebastianelli has mentioned 2 or 3 times the idea of the implant is non-biologic. So our tissues, when we stress our tissues, they will adapt. There's a principle in sports medicine called the SAID principle. Specific adaptation to imposed demands. And our tissues, our biologic tissues, will adapt and become stronger. Fortunately, with the implant, what you have is what you have, and it's not going to adapt. So if you're putting stressors on that implant, that aren't appropriate, that are far and above the loads that that implant should be subjected to. The only direction to go is it's going to break down and maybe eventually fail. So that's very important that the patient work with their physician, work with the physical therapist, the fitness expert, and do things that are recommended. And in general, those things that are recommended are those things where the environment is controlled. You know, going to play softball or something like that versus maybe walking or playing golf, things like that, where the environment is fairly controlled. That is the one thing that I think those individuals who undergo a joint replacement need to be thinking about.
Mm-hmm. Okay, we go to Tammy, who is calling us from Center County. Go ahead, please, Tammy.
Hi, I had a hip replacement back in 1999. I had trouble with it right after I had it. Not even a week after I had it, I was back in the hospital getting it cleaned out and a wound vac on it because I had some kind of infection. Mm-hmm. They said no, they never knew what kind of, nothing's never grew infection, so it wasn't a staph infection, or they would have told me it was a staph infection. So then they made me go for antibiotics, vancomycin, for months. Then they cleaned it out again and took the wound vac out. And after that, I had to go for like 3 months with vancomycin, and every day to the hospital for 2 hours to get the
intravenous antibiotics.
Yeah, and now it's acting up again. It was a striker hip was put in me, and now I have to go to Geisinger to have a medicine hip put in. Then afterwards, I'm going to have if my white cells stay okay, then I'll have to have another hip put in. Have you heard a lot of this? Or?
Yeah, it sounds like, unfortunately, you have a chronic implant infection with the associated osteomyelitis of the surrounding bone, and they're very challenging problems. And sometimes it has to do with blood supply to that area, and having multiple surgeries in that area means that the blood supply is not as good as we would like it to be. So the natural delivery of antibiotics to that tissue is not as high as it should be. So that requires high dose, long-term treatment in order to do that. And those kind of problems, unfortunately, in the best of hands, occur at least 1 or 2% of the time. And it's devastating when it occurs, and it's frustrating for us as surgeons because we can't prevent them all, even though we try like heck to prevent them all. And it sounds like you're going to go through a debridement, removal, a spacer, and then ultimately an exchange revision arthroplasty. And unfortunately, that's going to take probably 6 months minimum to get that all done.
So several months with her kneecap removed and a spacer, as you mentioned.
Correct. Or if it's a hip, it could be a hip spacer, it could be a knee spacer. It could be used in any joint, really.
Okay. Good luck to you. Thank you for your phone call. We go to Lisa. I'm sorry, Lisa is calling us from Pittsburgh. Your question, Lisa?
Hello.
Hi. You have a question for us?
Yes. Thank you for taking my call. Let me just give a brief history. I was born with bilateral congenital dislocation of the hips, and actually it was not diagnosed until I was 16 months old, and I was in the hospital until I was 3 years old. I was in a body cast, and what happened from that was that I had a leg. My left leg is longer, and it swells all the time. It even swelled when I was a child. So when I'm walking around, it swells up, and I've had thrombosis twice. And basically, what I want to ask is that a doctor told me in Pittsburgh that my leg may be longer coming out of the operation, and that would be devastating to me because it's already long already. And I was wondering how that could be avoided, or if not, then I don't know what to do. I'm lost.
Yeah, I can sense the the trepidation in your voice, and it's not an easy answer or an easy solution. And the leg length inequality after surgery is something that we tell our patients. Sometimes they're short, sometimes they're long. Most of the times they're within tolerances, and it's not an excessive amount. Occasionally you need to put a little lift in the shoe or in the actual base or the sole of the shoe itself. With your problem with congenital dysplastic hips, one side being longer is not unusual. And you need to put the implant in so it's stable, so that the muscle is under the right tension, so that even though you may want to shorten that limb if it's longer, you can't do that, because then it'll be unstable, which is a worse problem. It goes back to your original problem you were born with, which will be very, very painful and very, very disabling. So my advice to you is only do it when you get sore enough that you can't tolerate it. If you're not that sore and you control it with Aleve or Motrin or whatever, you should just live with it for a while and try to get more time out of it.
I've noticed that we've heard from a lot of women this evening, men too, but why are hip replacement procedures twice as common among women as they are among men?
Unrecognized congenital dysplasia, unrecognized partial dysplasias.
It's more common among women.
Yeah, absolutely. Just the angle of the pelvis in order to allow childbirth leads to different stressors on the knees and on the hips.
Okay. We go to Donna, who is calling us from Jenner's.
Hello.
Hi.
Okay. I am calling about my shoulder. I fell down my son's steps in May, and in July I had surgery done to it. I had it scraped. The doctor recommended either to have it scraped or have a shoulder replacement. So I decided to have it scraped. Okay, now I am having a lot of pain, like up my neck and down my arm from this. And I was wondering, what could I do, to relieve the pain that I'm having, like up clear into my neck and, like I said, down into the middle of my arm. And I have pain patches I put on, and I have had injection at the pain clinic in Johnstown, injected back in my neck and, into the back of my arm. And I was just wondering, what could I do here to relieve this pain? I have nothing for me to get up in the middle of the night, like 2 o'clock in the morning, to take a hot shower to get some kind of relief from this.
Any suggestions?
Well, I guess my first thought would be, it sounds as though she has had her neck evaluated and worked up. Have you had an evaluation for your neck by a physical therapist?
No, I haven't. And then after I had this here scrape, they sent me to like a place to exercise, and me going there, and they, gave me a schedule of the exercises to do. It bothered my left arm then, like it made it worse,
So the opposite arm.
To work with the right arm, because I had a rotor cuff done like in 2006 on the left arm.
Yeah. Well, if you're getting symptoms into the opposite arm, then I become even more suspicious of neck involvement in regard to your pain pattern. And I think that would be something that should be evaluated and worked up further. Because it would be very rare for your injured arm to refer pain to the opposite arm.
All right, thank you for your call. We have just less than 3 minutes remaining. We'll go to Buck, who's calling us from Du Bois. What's your question, please, Buck?
Hello. Can you hear me?
I can.
Yes.
I have a question regarding osteoarthritis in the shoulders, and I have severe osteoarthritis in both shoulders, and what to do with that. And I'm being told that joint replacements there are problematic, and the physical therapy ends up being a problem. What to do?
We hear lots about hips and knees, but not a whole lot about shoulder replacements.
How young are you, Uncle Buck? How young are you?
I think we lost it.
I'm 68.
68. I think 68 is young, but appropriate for joint replacement in the shoulder if you're having the kind of discomfort that you're talking about. And that should be discomfort that wakes you up at night, that has difficulty with doing any type of activity above waist level or chest level with resistance. And I think the key thing is to evaluate what kind of soft tissue your shoulder has, whether the rotator cuff is healthy. If the rotator cuff is healthy, then a total shoulder replacement where there's a cup put in and a ball put in is the way to go. And you know, nothing's guaranteed in life, obviously, but again, most of the time you'll be satisfied with that type of replacement, and it'll be a good functioning substitute for you, particularly in your age group. And if you keep your exercise and your sort of daily activities reasonably challenging, it could last the rest of your life.
A couple of seconds on what this might mean for him in terms of physical therapy?
Yes, if he elects to go ahead and have the replacement after he has that done, I think a big part of the rehab would be whether the rotator cuff is functioning or non-functioning. But either way, he would be doing some exercises to strengthen the muscles around the shoulder joint and trying to balance the shoulder so we could maximize his functional abilities.
All right, we've got lots of phone calls lined up. Sorry we can't take them all. I'd like to thank our guest tonight, Dr. Wayne Sebastianelli. He's an orthopedic surgeon with Penn State Orthopedics, and Dean Plafkin, the lead physical therapist at Penn State Orthopedics. I'm Patty Satalia. For all of us here at WPSU, thank you for joining us and have a good night.